Hello, everyone. My name is Dr. Christine Gould from Gynecology Associates of Gwinnett in Lawrenceville, Georgia. Today, I'm joined by Dr. Stephen Salmieri, who's a gynecologic oncologist also in Lawrenceville, Georgia. And we are here to discuss ovarian cancer because September is Ovarian Cancer Awareness Month. Hey, Dr. Salmieri, how are you?
Good, Dr. Gould. Thank you for inviting me to discuss this very important concept and diagnosis that impacts a large amount of women.
Yeah, that's terrible. So let's just get to some of the numbers. So ovarian cancer is the second most common gynecologic cancer in the United States and the most common cause of gynecologic cancer death in the United States as well. So it can be very deadly. In the US, there's about 22,000 new cases per year, and 14,000 women die each year of ovarian cancer. It's the fifth leading cause of cancer death behind lung cancer, breast cancer, colon cancer, and pancreatic cancers. 1.3% of women will be diagnosed at some point in their lifetime, and it's also more common in white women. So how do women present with this? Will you tell me some more about that, Dr. Salmieri? So I know there's an acute presentation. These women will come in and need immediate evaluation for things like pleural effusions or small bowel obstructions. Can you tell me more about that?
Sure. You know, the old adage about ovarian cancer used to be it's a silent killer, it's a masquerader. But usually it presents usually when the first sign of ovarian cancer comes, when the tumor starts to grow. And as you said, it could be acute with a pleural effusion, a bowel obstruction, but most of the time it's very insidious. It can start with just fatigue, bloating, early satiety when a woman feels that she's filled up earlier than usual when she eats a meal. It overlaps with so many other different symptoms, so it's non-specific. That's the problem.
Right, it is.
So, you know, I always tell my patients, look, get the word out. If anybody in your family, any female feels that something's just not right, use your instincts, go to the doctor, get an exam, get an ultrasound. Even if you're wrong, so what? You want to make sure you don't miss the diagnosis of ovarian cancer.
Oh, absolutely. So going back to the acute presentation that takes you like right to the emergency room, a pleural effusion is where some of the cancer cells get into the lining around the lungs, and that causes shortness of breath. So that shortness
Right.
of breath needs to be evaluated. And then with
Correct.
the small bowel obstruction, the cancer mass is obstructing the bowels, and women can present with nausea and vomiting, and that requires immediate attention as well.
Correct.
So, like you had mentioned, so for these women, if the symptoms are new in onset, they're more severe than expected, they're involved with coexisting things that are so very vague, fatigue, back pain, pain with intercourse, constipation, their period is irregular, they have indigestion. And if these things occur more than a couple of weeks, you should get it looked into. Wouldn't you agree?
Yes, absolutely. And again, don't underestimate the importance of these. Don't just kind of poo-poo it off and say, "Oh, it's no big deal," even though they're non-specific symptoms. And most of the time, it won't be cancer. But you want to assume the worst when it comes to your health and your body. You want to get it checked out. Don't wait. Typically, women wait longer because they're busy taking care of everybody else in the family.
That's very true. And so the reason why ovarian cancer can be so deadly is because it ends up presenting so late in the game. Is that correct?
Yeah, majority present stage 3 or stage 4 because of the insidious nature of it, because of the non-specific symptoms. So yeah, it makes it a little bit more difficult to treat it and even cure it.
Okay. So when we talk about, you said we need to go get evaluated right away. The first thing we can do is have a pelvic examination, whether it's by your gynecologist, and mostly we gynecologists do that, sometimes your primary care. So a pelvic examination would yield a mass in the pelvis. And then we physicians can evaluate that with ultrasound or even CT or MRI. So say I did an ultrasound and it looks concerning, I would then do a CA-125. A CA-125 is a blood test that we can use to evaluate if there's an increased risk of ovarian cancer. So tell me more about a CA-125.
So the CA-125 was first developed in 1980. It's what we call glycoprotein. So it's a sugar and a protein. Men and women make it. It's from our liver. And it was the first test that can give us an idea if something's going on in our body that may not quite be right. It's a source of inflammation. kind of like the C-reactive protein, which is another test that tells us something's quite not right in our body. It's non-specific, so that CA125 can go up from a multitude of things: stress, um, non-cancerous causes, arthritis, fibroids, smoking, and of course cancer and also non-cancerous lesions. It could be
Endometriosis, just having a
right.
period.
Yep. Anything. So it's very non-specific, but it is the only marker we have right now in the blood. It's not a screening test, but
Nope.
it is used when you suspect there's a mass in one of your female patients, and it's just another clue you can use to help you to make the diagnosis of ovarian cancer.
Right. So say we have an ultrasound that looks concerning. My next thing would be to do a CA125 and order a CT scan for my patient. What will we look at on CT? What would the findings be when we're really suspicious for ovarian cancer?
Well, the CT is great because it has three really good areas and structures in the body that it's very sensitive and specific for. One is ascites. You can see fluid that builds up in your pelvis or abdomen because the lymph nodes may be blocked, and the cancer cells themselves can make fluid. But usually it's because they block the lymph nodes. The lymph nodes could be enlarged. That's the second area where the CAT scan is very good. Lymph nodes should be a certain diameter, and if they're enlarged, that's a clue that something else is going on. And the third thing is the omentum, which is the covering of your bowel. A lot of times that will show nodules or thickening when it should be very thin. And of course, the masses themselves, you can see the masses on the ovaries enlarged with the CAT scan.
Okay, so the best thing to do, you have to do the CT scan. Would you also, at that point, if you highly suspect ovarian cancer, would you order the lungs just to look for pleural effusions in that setting? Or if they don't have shortness of breath, that's not necessary?
No, I usually get CT, the chest, abdomen, pelvis, because even if you don't have any symptoms, you could see some fluid and even some lung nodules that may not be big enough to present yet. But obviously, if it's in the lung or the pleural effusion, that makes it a stage 4. And that's important in prognosis and management as well. So, yeah, I think it's a great idea to get a CT of the lung and the chest along with the abdomen and pelvis.
Absolutely. So you mentioned stages just now. You mentioned stage 4. Can you tell me about the stages of ovarian cancer?
Sure. So there's 4 stages of basically every cancer. As we said earlier, ovarian cancer, unfortunately, majority, about 70% of women will present stage 3 or stage 4, which is advanced. Stage 1 is when the ovaries are just involved. It could be one or both ovaries. It's still stage 1. Stage 2 is when it gets into the pelvic area. So the fallopian tubes, the uterus, the pelvis itself would make it stage 2. Stage 3 is when it goes outside the pelvis, like the abdominal cavity. You have the intestines involved, the omentum is involved, any organ in the abdominal cavity. And stage 4 is when it gets into the liver, the lungs, the bones, the brain. If it goes deep into the colon, which is a new classification now from stage 3 to stage 4, if the tumor actually breaks through the wall of the colon, that also makes it a stage 4. So
Stage 4.
those are really the breakdown of each stage of ovarian cancer.
Okay. And so my next question will be, what women are at risk for ovarian cancer? What are the risk factors?
So as you said earlier, Caucasian or white women are a little more increased risk than other races, than Latinos and African American women and Asian women. Women from industrialized countries have a higher risk. Women that haven't had children or haven't breastfed, a slightly more increased risk than women that have had children and breastfed. But obviously, women that have had kids still get ovarian cancer. But again, if you haven't had children, that's a risk factor. Women that haven't taken birth control pills, they actually have a higher risk than women that do take birth control pills. So birth control pills are definitely a protective factor. And then genetically, if you're from Eastern European countries like Ashkenazi Jewish, they have a higher risk of ovarian cancer through hereditary and genetic factors. So those are the main risk factors. But sometimes we just don't know. You may not have any risk factors and end up with ovarian cancer.
Absolutely. Can you explain why pregnancy, breastfeeding, and birth control use can decrease someone's risk?
Sure. So the idea behind that is ovulation. So
Mhm.
if you can block the follicles from breaking through the surface of the ovary, and so there's an idea about the actual trauma of ovulating
Mhm.
that can cause damage to the surface of the epithelium of the ovary. If you can block that with birth control pills, and obviously when you're pregnant, you don't ovulate. You're amenorrhea for 9 months, basically. Anything that can block the ovulation of the follicles from the ovary and decrease the trauma can decrease the effect of the trauma on the ovary and to produce cancer cells. There's also a possibility that the cancer cells come from the fimbria or the end of the fallopian tube. Um, Sometimes we don't know if birth control pills can prevent that etiology, but the anovulation theory is basically due to trauma of the ovaries themselves.
That makes sense. And then the next thing you mentioned, just a risk from just based on your ethnic background, but there's also the genetic mutations BRCA1 and BRCA2, or BRCA1 and 2. They increase your risk of breast and ovarian cancer. So in your patients, in your practice, how many patients do you find that have the BRCA1 or BRCA2 gene mutation who have ovarian cancer?
So, in the general population, it's anywhere from 10 to 15% of women will have a BRCA one and two, one or two abnormality or defect. Now, in my patient population, obviously, I see majority of cancer patients. It's going to be a little bit higher, and a
Right.
lot of the studies that look at treatments now for patients that have these mutations, their populations are even higher. So you have to be careful when you look at the data and you want to extrapolate the data on how effective the treatment is. You have to look at it and say, you know what, that's not my patient population. But I would say, again, majority of my patients don't have the BRCA gene, but about 15% that do have ovarian cancer will have that mutation.
Right. And so if you have a patient who doesn't have ovarian cancer right now, and I have several patients who are BRCA1 or BRCA2 positive, what would be your recommendation about the prophylactic removal of their ovaries after they've, done having children?
So, basically when I counsel my patients, I try to quote a lot of the data
Right.
and the research, because you really want to give them solid information that they
Of
could go
course.
back and look at themselves. So recent data from the major cancer centers say that 35 years of age and older, if you're done with childbearing, then it is recommended that you can do a prophylactic removal of your tubes and ovaries. The question of removing the uterus has always been a little bit controversial, especially at the GYN oncology meetings. And I leave that up to the individual doctor to discuss with the
Right.
other factors. Is the patient a little bit overweight? Does she have risk factors for endometrial cancer? In my practice, I don't see the downside of taking the uterus out as well.
Right. I
Um,
agree with you.
you're not going to use it if you're done with childbearing, especially if you're taking tamoxifen to prevent breast cancer. That can increase risk of uterine cancer. So I base it on the risk factors, and then the literature suggests over 35 years of age.
Okay.
Yeah.
Who I highly suspect has ovarian cancer based on her symptoms, based on her ultrasound or CT, and also based on her CA125. So I call you, Dr. Salmieri, and I say, okay, I'm sending you this lovely woman. What are you going to do? How are you going to help her? What is the next steps for you?
Excuse me. Well, we need to get a tissue diagnosis.
Right.
So we either decide, do we do primary surgery or we treat her with neoadjuvant chemotherapy.
Okay.
Based on the extent of the disease, does she have ascites? Does she have pleural effusion? What's her performance status? Does she have a lot of medical problems? If she's not a good surgical candidate, I usually get a biopsy of the omentum, the nodules. You don't want to biopsy the ovaries themselves because you could rupture the mass
Right.
and spread it.
Cancer.
But if we get a diagnosis through the tissue of the omentum, the pleural fluid, peritoneal nodules, and she doesn't have a good case to go ahead with surgery first because she's got a poor performance status, so she has a lot of medical problems, I'll treat her with chemotherapy to shrink the tumor and then bring her to surgery after about 3 months. We
Mm-hmm.
call that interval tumor debulking. Get the cancer out That would include a hysterectomy if she still had a uterus, both tubes and ovaries, the omentum, and try to get rid of as much cancer as possible. That's called debulking. And then after surgery, about 3 weeks later, we bring her back and finish up the chemotherapy. And
Okay.
that's usually the basic way to treat patients. Or you could do upfront surgery if she has a good performance status. It doesn't look like she has a large amount of ascites or pleural effusion. Do the upfront surgery, then treat with chemotherapy, and then reevaluate with either a CT scan or a PET scan after treatment. And then we talk about maintenance therapy, whether or not she should stay on something to try to keep the cancer away.
Okay, that makes sense. And so your surgeries are done in an open fashion, correct? Because you cannot do this laparoscopically when it comes to ovarian cancer. So you're making a rather large incision on their abdomens?
Well, that's changed over the past few years.
Okay.
So a lot of my patients now, I am doing neoadjuvant chemotherapy where we actually shrink the tumors. And really, Christy, a lot of the patients are really getting more in tune with their bodies. So they're not presenting as late.
Good.
So a lot of my ladies that do present late, I do treat them with chemo, shrink them, so then I could do it minimally invasive robotic surgery.
Wow.
There's no difference in outcomes as far as overall survival or progression-free survival. Saves them a large incision, and they get back to being able to get chemotherapy much quicker.
That's great.
Now, obviously, if they do present with a large mass, acute phase, like you illustrated earlier in our discussion, then yeah, they have a large mass. They haven't taken care of themselves or haven't gone to the doctor in a long time. The cancer looks like it's obstructing her bowel. Then you're forced to go ahead and do surgery first, make a big incision, a midline incision, try to get all the tumor out as much as you can, and then do chemotherapy.
Okay, sounds good. And then so let's talk about what are the names of the chemotherapies, just in case someone is interested. What are the most common ones you use?
Sure. So again, according to the literature, that's how we decide which chemotherapies to use. And now it's been an exciting time in G1 oncology because we're tapering therapy to individuals based on the genetic molecular profile of their tumor. But the standard chemotherapy is called Taxol and carboplatin. And sometimes we add Avastin, which is another name is bevacizumab, which is a medication that actually attacks the blood vessels of the cancer cells. Wow. And then a lot of research now has gone into something called PARP inhibitors, which is actually a pill, which we can use now to try to keep the cancer away or actually even treat the tumor after chemotherapy if it comes back. And then immunotherapy is actually big now, where we actually use medications to boost your own immune system to fight the cancer. A drug called pembrolizumab, which is Keytruda. And also,
I've seen the commercials for that.
Right. And another drug called Opdivo. And there's so much research in these areas with immunotherapy and these PARP inhibitors.
That's very amazing. So that's just, if you don't mind. So if you are stage 1 cancer, you've had your surgery, and then you've probably had your chemotherapy. What does prognosis and recurrence look like for you?
So if you're stage 1, it also has a little bit complicated with different letters. There's stage 1A, 1B, 1C, and then there's grades. Grade means how aggressive the tumor is. So if you're a stage 1A or 1B, grade 1 tumor, pretty much we don't give chemotherapy. And your prognosis is excellent. A lot also depends on the histological type, like if is it a serous papillary tumor, an epithelial tumor, is it a clear cell tumor? That's a little more aggressive. But overall, if you're stage 1 and you don't need chemotherapy, your overall survival rate is anywhere between 90 and 95%, 5 years.
Wow, that's pretty amazing. Versus, say, stage 3 or 4, what are we looking at when we see that?
Yeah, that's a little more complicated. You know, we haven't made a huge impact over the last 20 years. Usually the overall survival for a stage 3 tumor is about 30 to 35%. Stage 4 is anywhere from 5 to 10%. But the little caveat there is you could present as a stage 3 tumor. You're able to get rid of all the tumor either with chemotherapy or surgery, and then your survival rate shoots up. As opposed to a stage 3 or 4, where you cannot get rid of all the tumor, and then your actual survival rate goes down. So not all stage 3 and 4s are the same.
Right.
Again, each patient is individual, but obviously it's much better to get this earlier, and your survival rate is much higher the quicker and earlier you catch the ovarian cancer.
And so this is Dr. Stephen Salmieri. And what is the name of your practice, Dr. Salmieri?
Georgia Gynecological Oncology, and we're part of Northside Hospital.
Very nice. Okay. Thank you so very much, everyone, for listening. I hope you found this educational, and please reach out to Dr. Salmieri or I if you ever have any questions. It was a pleasure talking to you all. Have a great evening. Thank you.